Jeff, can you hear me?
Now I do, yes,
Okay,
very well.
hi. And Federico is from the OECD, was supposed to be here in person due to the less than exemplary activity of the U.S. State Department. He could not get his visa in time, so he's kindly joining us this way. Jeffrey Sachs has a very long list of accomplishments and credentials. Head of the Earth Institute, perhaps the most recognizable. Jeff, we have a convention here of not running through everyone's long CV. Yours is incredibly long and admirable. And one of the things you've become involved with in recent years is talking about the need for single payer in the United States. And it's for that reason that we approached you to ask if you would speak to our conference. And we're very pleased that you're doing that. The plan, more or less, is that you can talk for 10 to 15 minutes, and then we hope you will take questions as well. And thank you very much for stepping out from your conference and joining us today. Jeff Sachs.
Great, thank you so much. Thank you, and thank you for having this important meeting, which is indeed extremely timely, and I hope very important for our politics. 2020 is going to determine a lot about the future of the United States, but if we elect Bernie Sanders or another progressive candidate, we have a real shot at reform of the healthcare system. And it's in that spirit that I want to make a few remarks. The overwhelming reality of our healthcare system, as you've been discussing, is that it is too expensive. We are spending in the United States about 18% of our gross domestic product on healthcare. Our peer countries in Western Europe, Canada, Japan, and others are spending generally 10 to 12% of gross domestic product on healthcare, and by all evidence are getting comparable or better health care treatment and access, as well as indisputably better health care outcomes, especially longer life expectancy. Now, longer life expectancy is not only a product of the health system, but is a product of the social system more generally. So I don't want to claim that our healthcare system is deficient on that count, but we certainly are not getting value for money. If you put this financing difference in dollar terms, our gross domestic product is $20 trillion. So the difference of spending 12% of GDP and 18% of GDP as we do on healthcare, 6 percentage points of GDP, is an extra $1.2 trillion a year. This is not news. It has been observed that the US healthcare system is by far the world's most expensive for 20 years at least. And the gap in costs between the US and our peer comparator countries has been widening over this period. The Institute of Medicine already back in 2011 or 2012 did a detailed study about the healthcare system at that stage when our GDP was only around $15 trillion, and found that the waste and excess costs were on the order of 5 percentage points of GDP, or about $750 billion then, and now it's well over $1 trillion. The real selling point for Medicare-for-All is that it would deliver a better healthcare system, obviously fairer, also more efficient, at vastly lower cost. This is the only way that it could conceivably be sold as well. Every media pundit that attacks the proposal on the grounds that it's, quote, too expensive, or how could we afford Medicare for all, is fatuous, because the whole idea of Medicare for all is to save hundreds of billions of dollars per year in health outlays. Of course, the health outlays through the federal government would increase, but the outlays to private health insurers would be essentially eliminated or nearly eliminated, so that the net effect would be a vastly lower cost system. The advocates of Medicare for all, starting with Bernie Sanders, need to make the case overwhelmingly that this would be a less expensive system. Yes, you can make the case that it would be fairer, more just by having universal coverage. That's important, but it's not going to win the politics. To win the politics, the costs have to come down. And since American households are struggling with their health care bills, a huge proportion of American households, 30, 40, 50%, can hardly make ends meet with their health care costs. The proposal to have a lower cost system could be a politically decisive win. Now, why is the US system more costly? It is not because we get more extensive services or higher quality services. There are now more than 20 years of comparative studies of the US and our peers. And the reason that our healthcare system is more expensive is that the unit costs of a hospital stay, a hip replacement, a insertion of a stent, any kind of specific intervention, including drug prices, are far higher than in the peers. So we spend more because the system is more costly unit for unit of outpatient visits, inpatient visits, specific procedures, diagnostics, and medicines. Why is this? It is largely because healthcare is a highly concentrated business with considerable market power of the private providers. In most of our cities, there are one or two or three major health groups. Of course, the whole drug industry is based on patent protection. That means monopoly pricing straight out. Of course, infamously, the federal government, because of lobbying activities, tied its own hands in negotiating with drug producers under Medicare, for example. So we have turned the healthcare system into a series of local monopolies or oligopolies across the American landscape. And we are then utterly vulnerable to the market power of the health providers. And the result is this vastly overpriced healthcare system that is leaving a significant proportion of Americans, as I said, up to half of Americans, struggling to cover healthcare bills, co-payments, out-of-pocket expenses, prescription drug prices, long-term care, and many of the services that aren't even covered under their basic packages. We have not the need for theory, but the practical fact that Canada, UK, France, Germany, Scandinavia, Finland, Belgium, Netherlands, Spain, Italy, Sweden, Spain, Italy, Japan, all have a near or universal coverage at vastly lower costs. So this isn't a theory that this can be done. This is a reality. But how to get the cost down is a basic political economy and management and administrative set of challenges. Where are these extra costs? Part of it, as you know, is a vastly more expensive administrative system, which reflects the completely disjointed and oligopolistic health delivery and an incredibly complex payments system. So part of the savings can be wrung out of vastly simplified administration and cost recovery in a single payer system. Part of the increased costs in the US are reflected in vastly higher salaries of hospital administrators. A typical not-for-profit system in the United States, and again, I said not-for-profit, pays the hospital administrator of a large not-for-profit system several $1 million a year. In Europe or in Canada, this would be several $100,000 per year. So the savings in costs of high salaries and profits of the health providers is a second area that would be squeezed. Of course, when you have monopoly rents, you also have rent-seeking behavior in the form of advertisements and other inducements in attracting clientele, and this would also disappear. In general, the private advertising promotion of healthcare is a waste of time and money, and also often with pernicious outcomes, such as the opioid epidemic, which was pushed on America by Purdue Pharmaceutical and other private companies that avidly push their products in a completely indecent and indeed criminal manner. So this would be saved as well. But there's another area that we need to take into account, and that's doctors' pay, because specialty doctors in the United States, say orthopedists, radiologists, and others, make many times more than in our peer countries. $750,000 or $1 million a year is routine for various kinds of specialties, whereas in Canada or Europe, the salaries might be $250,000 a year maximum. So this is also a major political challenge. It's why the Democratic Party in general does not back single-payer system, because the healthcare lobby and the healthcare contributions to campaigns is probably the single biggest lobby in the United States at this point. And you can look up the details at opensecrets.org. The industry pays a fortune for the privilege of charging us monopoly or oligopolistic prices. And there are a lot of healthcare providers that are doing very well, thank you, under this system. And so there's a lot of resistance there as well. So we need to scope out where these savings would come from and the level of ambition of saving. It's not that we can't afford Medicare for all, it's we can't afford our current system, but moving to Medicare for all would mean a major reduction of outlays of several percent of GDP now earned in high salaries, in profits, in rent seeking, dissipated in advertising, it dissipated in administrative costs that would disappear. And this is really the practical challenge. First, getting that done over the objections of a huge and powerful lobby, the largest single economic sector in the United States, and finding a way to do it that is efficient and does not break the system during the transition. I'll just say that there are 2 or 3 major issues that need to be resolved that are very, very big and complicated issues that I'm incapable of providing any definitive answer. One is the reimbursement mechanisms. The simplest proposals of Medicare-for-All use Medicare's reimbursement for different diagnostic groups for different categories of reimbursement, but basically maintain a fee-for-service structure, but at lower reimbursement rates that Medicare uses. This would certainly provide hundreds of billions of dollars per year of reduced costs. An alternative is, of course, to move to negotiated budgets for hospitals or health provider systems, a more capitated and risk-bearing mechanism. In general, this would be more efficient. Almost surely it would require a decade of transition from our largely fee-for-service to a largely capitated structure, though part of that is underway even under Obamacare. The second major question is how to shift the financing from the outlays of private insurance to the government, which would then be responsible for all payments under a single payer system. Again, the very obvious point is that what is shifted onto government will be much less than what is eliminated in paying the private providers, so the net savings for the economy will be very large. We want to make sure that the net savings for almost all households is also very significant. That's the selling point, and I think the valid point. So how can that fraction of current flows to private health insurers be shifted to government in an effective manner? One way would be essentially to have premia paid to Medicare-for-All rather than premia paid to private insurers. But there's probably an even more fair way, and that is to fund the incremental spending by government out of general revenues rather than out of specific earmarked payroll taxes or public insurance premia. Out of general revenues, that means out of income taxation, a reversal of the unjustifiable 2017 tax cuts that went to the richest Americans. That would pay for some part of the increased spending, raising taxes on the wealthy, whether partly through a wealth tax or simply higher taxes on personal income and so forth. Probably on net, right now, the government spends something on the order of 9% of GDP on health spending, and the private spending is around 9%. Most of that private spending, the 9%, would fall to 1 to 2%, only on supplemental or complementary insurance. And the government portion would rise by perhaps 4 percentage points of GDP, which would have to come out of taxes or public premia in some way. The net savings, however, if done properly, would be at least 4 percentage points of GDP. That's $800 billion a year. But it could be as much as 5 or even 6% of GDP if it was a very, very aggressive cost-saving system. Well, there are lots of details that nobody has worked out. Any realistic chance of success of this will need to show that the large majority of households will pay less, will still be able to have their providers, and that the remuneration that remains will be decent remuneration that will give good incomes to the health industry, but not to the untenable extent that we have today. And I believe as of yet there are no fully formed plans that meet these criteria. Obviously, this would be an effort over at least a year of legislative action, but the fundamental selling point, in my view, would be cost saving. And it would be a reduction of the administrative losses, the ultra high salaries, the profits, the advertising and other wasteful expenditures in our health system. And the ultimate selling point that makes this realistic is the fact that the United States alone, of all high-income countries, is in the bind that we are in. What we need to accomplish is not guesswork like a moonshot. It is emulation of what is happening in all of our peer countries. So those are just a few thoughts, I hope useful. And let me turn the microphone back over to you. Thank you very much.
Thank you very much, Jeff. Very thought-provoking and inspiring comments. Did you have a few moments for questions?
I do, absolutely.
All right, great. So we're going to see if this works. We have these roving microphones. Who are the microphone masters? We should have two folks, and we're going to give it a shot right here over in this. Who's got a microphone?
Great, yeah.
You have one there? Go ahead.
Okay.
Please identify yourself.
Yes,
and
hi. I'm Barbara Cummins, a retired RN.
Jeff, can you hear?
I do.
My question has to do with profiting, okay? The health sector is now at $6 trillion in value on Wall Street. It's gone up 200% since the Affordable Care Act was implemented. It's gone up 15% in the last 3 months, okay? What can we do about this? Is this driving cost, and what can we do about it?
Well, the high returns on Wall Street are a reflection of these monopoly profits that I'm talking about. They are not a cost driver. They are really the reflection of an industry that earns a phenomenal amount of money, and it gets reflected in high share valuations. That's the scam. We should understand very well that the Affordable Care Act was not in any way, shape, or form designed to reduce costs. It was designed to increase coverage modestly, but importantly. But the trade-off that the Obama administration accepted was that it courted the support of the health industry by saying you'll have even higher profits, you'll have even more business under our proposal, and we will not aggressively aim at cost reductions. So this was a conscious policy, not a side effect. The idea was to expand coverage, to guarantee access even for people with the prior conditions or who lose their jobs, but it decidedly was not a cost containment strategy. A single payer system is a cost containment strategy. That's why we have the divide in the Democratic Party. Bernie Sanders is telling the truth. We have to control costs. Most of the Democrats are taking campaign contributions from the health industry, which actually gives predominantly to the Democratic Party candidates. That's the divide in the Democratic Party. Bernie's telling the truth.
Karen?
I have a question. Thank you very much for this inspiring speech. I'm a geriatrician, and a lot of my practice is elderly patients. I deal with Medicare 90% of the time, and I will testify that it is the best healthcare out there. I have to say, however, that we can do better as society. Currently, the reimbursement for geriatricians, I would have to say honestly, is not up to par with the subspecialists. And there is no incentive to, for example, go and do home visits, where in reality, the data shows that you actually can do a lot of savings if you do prevent hospitalizations and delaying, care. So one thing I need to see actually in the new proposal is that there is emphasis on elderly care and how we can provide for people in their own home, preventing hospitalizations, providing incentives for doctors, to be honest with you, to actually take the time and the trip to go and see a patient at home. My aunt is a practitioner in England, and the reimbursement for primary care physicians in their system is quite actually lucrative, and there is a lot of incentives for young doctors to go into primary care. Whereas the reality right now in our healthcare system is there is disincentive for doctors to go into primary care. And we're seeing, unfortunately, more of that being put on the shoulders of the, physician's assistants and nurse practitioners, which are wonderful providers. But there are times when you need the clinicians to be the one making these visits home. So I'd love to see your thoughts on that. Thank you.
Thank you very much, and thank you for what you do. I'm married to a primary care doctor, a pediatrician, actually, the other end of the age spectrum, but I'm a huge believer in primary care, and it is not the strongly remunerated part of our healthcare system, that's for sure. Our healthcare system is also not designed for social determinants of health, and aging is a part of that. Older people often are lonely or isolated or in difficulty and incapable of addressing their problems on site at clinics or hospitals and need home visits. That doesn't have to be doctors also. Community health workers can play a phenomenal role at low cost. But typically, the hospitals have not been very interested in that. They're not interested in preventative care in general because they're reimbursed for services. They're not reimbursed on a capitated basis. And many of our leading academic hospitals are in desperately needy communities, but have almost nothing to do with the communities where they're located in except through the emergency room. And so the issue of elder care or care of the poor requires a social perspective and a social outreach and an outreach at home and an integration typically with other social services as well. Again, in socially oriented countries, not the United States, these social services would be normally provided because that is what decent government does. In the US, these services are actually not even present in general. So a truly reformed system would be integrated with the underlying social determinants of health. We have so many epidemics of unhealth, not only the opioids, the obesity epidemic, but the challenges of the elderly is going to be an increasing problem because of demographics. And so I agree with your points. And again, I can tell you, as far as I know, there is no systematic blueprint available right now because we have not been in a true reform mode for decades. Even with ACA, was not really reform except to bring people into the system, which is valuable, but not to reform the system. And so that's what should be occasioned by a transition to Medicare-for-All.
Do you have time for one more question?
I do.
I'd like to ask, how in the world can we overcome the money that the insurance companies pump into this thing and provide us misinformation? Every time I hear politicians or anyone talk about Medicare for all, universal health care, they talk about, oh, it's going to cost so much. Well, we spend $9,700 a piece in the United States for health care, in Canada, $4,400 a piece. It can't cost more, it saves money, and it's like having a balance sheet that you publish for a corporation that only shows the liabilities, and it doesn't show the assets. We want a bottom line. How are we going to get a bottom line if there's all this money going into misinformation? We don't need to import it from the Russians. We got all the misinformation we need from the insurance companies.
Apologies, I'm going to while I agree with everything you said, I do ask that people keep questions short so we have let our speakers have an opportunity to respond. Jeff?
This is exactly the battle that we're in because the mainstream media, so-called, wants to report on the higher costs of government spending, not on the overall net reduction of healthcare costs by the elimination of these gargantuan private outlays. So this is absolutely the challenge. Bernie tries to say this every day. Your healthcare costs will go down because what you pay now or your employer pays, which comes out of your wages, will be eliminated, and what will be increased in government outlays will be much smaller than what has been eliminated. We have to make this point every day, that the United States system is twice as expensive or more than our peers, that this is a cost saving, not a cost increase, that household bills will go down. The more that the system can be specified of how this transition will work, perhaps the more households can see it. But your basic point, that what we hear every day is just nonsense. When Bernie or others is pressed, how are you going to pay for this? We're paying for it twice as much right now. So what we're going to pay for is much less. But that is the deliberate distortion that is drummed into the mainstream pundits and is paid for by the healthcare lobby. That's what we're up against. We have a few crucial weeks ahead for this message to be heard very, very clearly. I think it's extremely important. The Republicans, of course, will never do what needs to be done. That's by core design of their political party. And the Democrats are split in half. And Bernie is the one telling the truth on this.
Thank you very much.